Good afternoon. Good afternoon, everyone. At this first Tuesday lunch of the Vasculitis Awareness Month for the ERN-RITA. I'm really happy we're having the vasculitis webinars this month. It's an important month for RITA and RITA members and RITA Centers of Excellence, where we, pay attention to all the rare manifestations of vasculitis, and we hope with these webinars to raise more awareness about these sometimes very difficult diseases. So for today, we will talk about cryoglobulinemic vasculitis, and for the rest of the month, we have three other super interesting subjects: CNS vasculitis, IgA vasculitis, and prediction of relapse in ANCA vasculitis. So we hope you will tune in every week to get the latest and the newest on these matters. For today, I welcome our team from Turin, the Center of Excellence of the San Giovanni Bosco Hub Hospital in Turin. They are very well recognized and highly esteemed members of ERN-RITA. And as you can see, they, as a Center of Excellence, have a very high focus on autoimmune diseases and immunopathology. And I'm really honored that Professor Roccatello will be the second speaker for today in this webinar. Professor Roccatello is Professor Emeritus of the Nephrology at the University of Turin, and also head of the San Giovanni Hub Hospital in Turin. And he has, he probably does not need introduction because we all know his track record on autoimmune diseases. He has founded the Center of Excellence for Nephrology, Rheumatological and Rare Diseases, and coordinated the interregional network in northwestern Italy. So thank you, Professor Roccatello, for being here with us, and looking forward to your presentation, which will be introduced by Professor Sciascia. And Professor Sciascia is full professor in nephrology at the Department of Clinical and Biological Sciences and Nephrology at the University of Turin. And it is not a coincidence that you both will be talking about cryoglobulinemic vasculitis. Within the ERN, we are developing a guideline, and I'm very pleased that both of you are chairing this, the guideline committee, and very happy that you were willing to run this webinar. And with that, Savino, I would like to give the floor to you. Just one house rule. Questions to everyone who is attending can be typed in the Q&A box of Zoom. I will receive them and try to address them at the end of both presentations. Thank you. And Savino, the floor is yours.
Good morning, good afternoon, or good evening, whenever you will attend in this webinar. Really a pleasure for myself and Professor Dario Roccatello to given the opportunity to talk about cryoglobulinemic vasculitis today to the RITA-ERN family, community, and hopefully beyond. So it's my particular pleasure to set the stage for this rare and still challenging condition. So this is briefly the agenda. We will move from definition, a little bit of pathogenesis, clinical presentation, then to tackle together probably one of the main topic in this condition, that is new and upcoming therapeutic strategies. We want to start with a little bit of definition, because oftentimes in rare disease, starting for what we are talking about is the key steps to set the stage. So in the world of cryo, we have to be sure that three main definitions are well shared. The first of all is the definition of cryoglobulins. So when we are talking about cryoglobulins, we are talking about the immunoglobulins that have a specific characteristic to precipitate in vitro when the temperature drops below 37 Celsius. When we warm, they redissolve again. Cryoglobulinemia is the presence of cryoglobulins in the circulation of the patient. So cryoglobulins are the IgG, IgM, and IgA per se. Cryoglobulinemia is the condition in which we have circulating immunoglobulins, while the clinical presentation, so the association of the cryoglobulins and the skin, kidney, liver, and neurological manifestation build up the concept of cryoglobulinemic syndrome or cryoglobulinemic vasculitis. And in this session, we will mainly focus on the clinical presentation, that is the full-blown disease when the persistence of cryoglobulinemia affect mainly through a vasculitis process, small and medium-sized vessel. Historically and also clinically, the cryoglobulinemia world has been divided according to the type of immunoglobulin. We have usually referring to a type 1 when we have a monoclonal expansion of immunoglobulin, mainly IgM, and this condition is often found in B-cell lymphoproliferative disease, and overall has been estimated that this type represents roughly the 10% of the whole cryoglobulinemic world. And then we have other two types, type 2, the most prevalent, and type 3, in which the cryoglobulin are different when compared to the type 1. And in the type 2, we are monoclonal Ig immunoglobulin, mainly IgM with kappa restriction, recognizing polyclonal immunoglobulin. While in the type 3, we have polyclonal IgM recognizing polyclonal immunoglobulin. In this setting, especially the last two, we are referring together as mixed cryoglobulinemia. Moving from the definition to the prevalence, we have to make some assumptions. It often happens in rare disease. The epidemiology, incidence, and prevalence of the disease is scattered and mainly depends to the methodology that some studies have reported. In these settings, most of the information that we have comes from the infectious world and the hematological world. Overall, it's been estimated that the prevalence of cryoglobulinemia clinical syndrome is about 1 per 1,000 K person in terms of prevalence. It's also important to note that while the clinical syndrome can be differently detected, we have more solid data about the presence of circulating cryoglobulin across different diseases. And this cartoon mainly summarizes some of those. We have a prevalence as high as 20% in HIV patient. We have a roughly between 15 and 25% in overall connective tissue disease, but the main and probably most recognized area in which cryoglobulin has been studied and investigated is in hepatitis C, when up to 65% of patients can be found positive for these immunoglobulins. When moving to the hematological world, also we are able to provide some estimation when we have up to a third of the type 1 cryoglobulin identified in monoclonal gammopathies of some clinical significance. We have roughly the other third of Waldenstrom microglobulinemia, and the remaining between non-Hodgkin lymphoma, multiple myeloma, and more rarely chronic lymphocytic leukemia. And again, this cartoon provides some estimation. But as previously mentioned, if we want to focus on the main core where most of the data comes from is the world of hepatitis and mainly chronic hepatitis C, where up to 40% of patients with HIV has been estimated to be carrier of cryoglobulins. Other data comes also from our nation, Italy, where Professor Roccatello led a study in which was possible in pioneering the prevalence of cryoglobulinemic in the context of patients with nephritis. And this study set a cornerstone in identifying that the most prevalent was type 2 cryoglobuliniemic, so the mixed cryoglobulinemia, with the majority of patients with nephritis also being positive for HIV antibodies and RNA positivity, so setting a cornerstone in define the prevalence and the characteristic of this disease. Moving to pathogenesis, again, pathogenesis might probably need a talk for itself because, as we might guess, different pathogenesis mechanism has been investigated according to the underlying disease. But just to summarize and to keep the main pillars of the pathogenesis, we can set the stage as a cryoglobulinemic of two coins of two sides of the same coin. When we refer to the type 1, the key word is hyperviscosity. And one of the clinical main manifestation is microthrombi occurring in small vessel. And in the cartoon taken for a report of a case series is a very emblematic manifestation of what can occur on the skin level. And this has been proven not only in observational clinical studies, but there are also mice and murine model proving that the hyperviscosity is the key trigger in type 1. When moving to the mixed cryoglobulinemia, the most of the data that we have, as previously said, refer to the role of hepatitis C virus. The pathogenesis is mainly investigated to a key point that is a shared receptor, that it is CD81, that is common between hepatocyte and B cells. And since this is the key mechanism through which the hepatitis C virus can, on one side, infect the hepatocyte, and on the other side, also being internalized between the B cells. This has been a cornerstone in the understanding the mechanisms through which cryoglobuliniemic expand, and at the same time, as we will hear later, also a cornerstone in understanding potential pathogenic and target therapy, because understanding the B cells as the key mechanism and reservoir of the B cells, also targeting this population of cells, make a potential and very appealing therapeutic target. Once we have the internalization of the virus, the gene translocation happen. This prevents the B cells to go through a mechanism of apoptosis, and this is where the polyclonal and polyclonal expansion happen up to the formation of immunocomplex formation. This is the pathogenic second hit and second step after the expansion of the B cell. That is a key point, because once the immunocomplex has formed, we are leading to the clinical manifestation. This can be leukocyte diapedesis, direct tissue damage. In fact, one of the whole mark of the disease is leukocytoclastic vasculitis. We also have the skipping the phagocytosis mechanism happening to the macrophage system due to the interaction of the immunocomplex, and similarly, the immunocomplex, mainly due to the IgM presence, are able to escape the erythrocyte transport system mediated to the complement receptor 1, and this may lead to the persistence of the immunocomplement in circulation, leading to the tissue damage. Clinical presentation, of course, is the main reflex of the pathogenesis that we have briefly summarized. And we have a continuum of different manifestations moving through asymptomatic aspecific patient in which cryoglobulinemia can be detected, usually accompanied by mild symptoms, rheumatoid factor positivity, and low C4 complement level, up to very life-threatening manifestation in which neurological, kidney, and skin involvement can be present. When we want to summarize between this spectrum of asymptomatic patient to life-threatening condition, purpura, so skin involvement, weakness, arthralgia, and sometimes myalgia, liver involvement, renal involvement, and peripheral neuropathy are the main clinical presentation, and we will tackle on them a little bit one by one. Again, as previously mentioned, when we are thinking about skin involvement and where the biopsy can also be important, leukocytoclastic vasculitis is one of the histological hallmarks that can be useful in better characterize the diagnostic pathway of this patient. Just briefly moving one by one, musculoskeletal is very common complaint in patients with this condition. Usually we have arthralgia and myalgia much more frequently than active inflammatory arthritis. Metacarpal and proximal phalangeal joint are the main clinical complaint, but also knee and ankles can be affected. Peripheral neuropathy is its prevalence varies across different studies, but there is a general consensus that oftentimes can be subclinical, and in studies systematically performing electromyography for those patients has been found as high as 80%. So this is something that we have to remember and actively investigate in this patient, because not necessarily this is clinically complained, but can be subclinically reported and investigated. In the full spectrum of these manifestations, some patients can also present with severe peripheral neurological manifestations such as mononeuritis multiplex and combined sensomotor neuropathy. Renal involvement is another pillar of, if not the pillar, of the clinical presentation, and mainly one of the main triggers in the prognosis of this patient. Has been estimated that nephritis can be found as high as 0.5% of patients with HIV. Extrarenal signs of mixed cryoglobulinemia can present sometimes before the kidney involvement, but not necessary. And if there is one take-home message that we always want to stress, and this is one of the pillars of Professor Roccatello teaching, is that diagnosis is the central point to push forward a correct diagnosis of these patients. Clinical presentation when talking about the renal involvement varies again. Roughly half of the patient can present with urine abnormalities. In this case, we have subnephrotic proteinuria, microscopic hematuria, with or without chronic kidney insufficiencies. Roughly a quarter of the patient, or 20%, can present with nephritic syndrome. 15%, and this is again an estimation of a study conducted through the Italian network, can also present with acute nephrotic syndromes. Acute renal failure can be present, or it has been found in up to 10%. Moving from the clinical presentation to the histological feature, diffuse membranous proliferative glomerulonephritis is definitely the most important histological finding at the biopsy level. And just to provide you some cartoon here to share some histological picture, this is a membranoproliferative pattern with endocapillary proliferation, and some deposit can be evident at the level of the capillary lumina. We have another cartoon here showing double contour and the presence here of deposit can be found. And here, those are magnified. This is another, I would say, very didactic cartoon showing the intraluminal pseudothrombin consistent with the presence of cryoglobulinium. These are present in the lower right part of the cartoon. Even without being an expert pathologist, we can here easily identify the pseudothrombin deposit, very evident again in the lower right part of the cartoon. And these are again magnified here. In terms of immunofluorescence, we can find granular IgM, like in this case, or IgG, with complement deposition. These are mainly to the subendothelial space, mesangium, and pseudothrombi. And again, if we pay attention, if we keep in mind the previous cartoon, we can see that those who identify at optical microscopy as pseudothrombi here are positive at immunofluorescence. The clinical investigation can be also performed and confirmed with electron microscopy. Here we can find organized deposit of cryo in the subendothelial and in the intramembranous location. And this is another key point and cornerstone of the electron microscopic finding, which we have engulfed monocyte macrophage associated with the deposit in the subendothelial location between the GBM and the endothelial lining. At the electron microscopy, again, from mainly an educational purpose and a didactic purpose, cryo can be identified, and this is a very nice example in which we can find microtubular up to 10-25 nanometer with an annular structure, and they can find in a transversal section a ring of 30 nanometer. These are pathognomonic. If your pathologist at electron microscopy finds this kind of pattern, you have to think about Cryoglobulinaemic vasculitis, and these are bigger when compared to amyloidosis fibrillar and in pattern very characteristic. Again, wrapping up the clinical manifestation, if there is a take-home message from this side, is the evolution of a spectrum from asymptomatic laboratory finding, in which the positivity of rheumatoid factor and low C4 has to make think about ordering cryoglobulinemic as a test, to the full spectrum of clinical manifestation. And again, to wrap up, purpura, weakness, arthralgia, liver involvement, renal involvement with the clinical pattern that we have shared, skin and peripheral neuropathy are the cornerstone of the cryoglobulinemic vasculitis or syndrome. Here, just to share some cartoon, this is from our cohort in Torino with a severe skin involvement in a patient with cryo. Again, what was present and evident on a clinical level on the skin of the patient was confirmed bioptically. And again, here we can find what we were mentioning before, the leukocytoclastic with the debris of neutrophils evident at the histological level that are very suggestive from a histopathological point of view of the vasculitic process. Other manifestations can also be present, and lymphadenopathy, splenomegaly can occur between 20 and 30%. Abdominal pain can also be referred, and of course, especially in cases with a concurrent hepatitis C infection, liver abnormalities are present. It's also worth to say that most of the liver involvement reflects the underlying cause rather than to be specifically pathogenic for the cryoglobuliniemic presentation itself. Now we move briefly to the therapy, and I think that the first link between therapy and the presence of cryoglobulinemic vasculitis take into account the central role of hepatitis C, of course, is the antiviral therapy. The story of the treatment of hepatitis has always been a crosstalk between the infection and the immunological world. So when the direct antiviral agent were becoming in the mainstream, of course, the direct link between the potential curative role in the setting of cryoglobulemic beyond hepatitis C alone was very promising. And this is where, starting from the second half of the 2015, 16, and 17, most of the research has been focusing in the setting of cryoglobulemic. Of course, we all agree that this medication represented a cornerstone and one of the biggest recent achievements worldwide in terms of public health. They have the ability to be extremely efficient in their antiviral efficacy, reaching the 100%. And so this is one of the biggest achievements in medicine. And this is mainly when we think about hepatitis C virus infection. When we want to translate this experience into the cryoglobulemic world, we have to make some consideration. In fact, if on one side, the use of direct antiviral agent has been supported by different societies across the globe in terms of the effect and the ability, as we say, to have up to 100% of antiviral response, different experience has been to take into account when putting and directly translating this experience into the world of cryoglobulinemic vasculitis. In fact, experience has been very heterogeneous from this perspective. The quality of the study is heterogeneous. Systematic biopsy, either skin and most importantly kidney, has not always been performed in the reported study. So if on one side the role of direct antiviral agent is proven and has been representing a milestone for the treatment of hepatitis C, some consideration are warranted when moving directly into the world of cryoglobulinemic vasculitis. Among others, for instance, this is the studies that is mainly focused on the long-term efficacy of interferon-free antiviral treatment in the context of cryoglobulinemic vasculitis. Renal involvement in this case was not systematically proven by a biopsy and was only in 25%. And again, reading critically this experience, if on one side the role of direct antiviral agent was confirmed on the hepatitis C, some consideration are still to be put when considering the role on cryovasculitis per se, because also in this experience, at least half of the patients remain positive for cryoglobulins, proving that the immunological mechanism underlying the production of immunoglobulins might be independent from the hepatitis C infection per se once the disease is triggered. For instance, this is just an anecdotal example in which we can confirm this consent in which is a patient of 55 years old, man with a nephrotic level proteinuria, a slight contraction of the kidney function, hematuria evident at the urine analysis, consumption of the complement, both C3 and most significantly C4. It was confirmed an hepatitis C virus infection, genotype 4, a cryoglobulin of 0.5, cryoglobulin detected in the serum of the patient, both polyclonal, IgG and IgM, with a strong rheumatoid factor. So this characteristic fit the patient for a further investigation in terms of renal biopsy. This is what we found was a mesangial proliferation and endocapillarity hypercellularity with segmental distribution, with a strong immunofluorescence for IgM, C3, IgG, but also C1q and IgA with intramembranous and subendothelial pattern. So taking together both the clinical characteristic of this patient and histological will fit the diagnosis of a type 3, so polyclonal IgM with polyclonal IgG. The patient was treated with direct antiviral with sofosbuvir and ribavirin for 6 months. And this is what it was observed, a complete response in terms of hepatitis C infection, RNA got negative, but at the same time, the kidney situation was stable. Proteinuria was 3.4 at the end of the therapy and stayed, if not increased, at the nephrotic level after 18 months from the treatment with persistent hematuria across all the treatment. In order to further investigate the setting, a second kidney biopsy was performed. Immunofluorescence was confirmed to be positive with a similar pathway, but what was more striking was the evolution of the disease in terms of tissue damage, because we moved to 11 out of 18 sclerotic glomeruli with a diffuse thickening of the GBM, proving that the hepatitis C response was not mirrored by an attenuation of the kidney involvement, which was indeed promoted to a pure kidney damage as expected in the glomerulosclerosis. So the lab was confirmed as hepatitis C hepatitis C RNA was negative, but the kidney did not respond. Proteinuria was still nephrotic level. Microscopic hematuria was confirmed. Kidney function was stably contracted. And as we say, we found sclerotic glomeruli in the majority of them. So this anecdotal case was also a little bit a summary of our experience, in which the point is that once the immunological manifestation is triggered, is the point in which treating ACV alone might be not enough, because the persistence of B-cell clone after the eradication of hepatitis B might still not be enough to cure the damage related to the immunoglobulins circulating. So once the immunological trigger has started, the immunological disease has to be the one that has been treated. And with the idea of immunotreating, immunomodulating the response, I leave the floor to Professor Roccatello to continue to the further steps in how to treat cryoglobulinemic vasculitis, new and upcoming perspective. And I thank you all for the time.
Thank you, Savino. Next, please. Standard immune suppression. Standard immune suppression has a key role in the treatment of cryoglobulinemic vasculitis. It includes methylprednisolone pulses followed by prednisone rapidly tapering in a few months, and cyclophosphamide administered either orally or intravenously, or more recently, MMF, mycophenolate. In extremely severe cases, In extremely severe cases, including rapidly progressive glomerulonephritis, deep necrotizing skin ulcers, severe polyneuropathy, escalation therapy includes plasma exchange, usually 40 to 50 milliliter per kilogram per session. Notably, cryoglobulins are especially susceptible of removal using the double filtration technique that has a more limited impact on blood protein concentration and does not require liquid substitution. So double filtration can be considered the standard of care for extracorporeal treatment of cryoglobulinemia. Next. Of course, in these cases, we have to treat patients with direct antiviral agents because of the possibility of re-exacerbation of hepatitis C virus infection. Next. The next, okay. However, in the last decade, a pivotal role of B-cell depletion therapy has been recognized. The anti-CD20 monoclonal antibody rituximab acts as at the very first step of pathogenetic cascade of mixed cryoglobulinemic vasculitis, blocking B-cell proliferation and thus IgA production, which is critical for both cryoglobulin production and deposition in the glomeruli. Next. The Italian multi-center control trial that was organized by the RITA from Udine compared the outcome of rituximab treated patient with the outcome of patient treated with the so-called best conventional therapy, consisting mainly of steroids, cyclophosphamide or azathioprine, and or plasma exchange. Patients under rituximab showed an impressive better outcomes. Next. These results were confirmed in a smaller controlled study performed in USA, with again impressive differences in activity score and duration of remission following rituximab and the conventional immunosuppressants. Next. However, these controlled studies, suffered of the lack of long-term data. This is our experience. Half of these 31 patients have more than 5 years follow-up. They included 29 31 patients, 29 infected by HCV, and 12 intolerance to standard therapy, 9 resistant to standard therapy, 29 with peripheral neuropathy, and 16 with severe renal involvement, essentially diffuse membranoproliferative glomerulonephritis. They were treated with the so-called improved over standard protocol of rituximab, including 4 weekly doses plus 2 doses of 335 milligram per square meter after 1 and 2 months. Only 5 patients received also steroids, and no patient received immunosuppressant. The next. Serum creatinine and especially proteinuria significantly improved. And the next. Despite the absence of antiviral therapy, viral load not only did not increase, but even significantly decreased because of elimination of a natural reservoir that is infected lymphocytes. The next. The effects of skin ulcers were impressive as well. The next. So, what about the international, previous slide, Savino, previous again. What about the international therapeutic guidelines? Next. Let me say that we have to throw away the recommendation of both the American and the European Association for Study of Liver Disease. They do not base on robust evidence. And also please consider cautiously the KDIGO guidelines that do not apply to real life. Let me suggest to follow the up-to-date indication just published. Rituximab has a key role in treatment this manifestation. All the cryoglobulinemic vasculitis manifestation, including skin necrotizing ulcers, multiple mononeuropathy, glomerulonephritis. You can use lymphoma protocol as employed in Snell experience, arthritis rheumatoid protocol, the RITA trial, or what we suggest, because it's associated with a lower rate of relapses, in the improved or extended protocol, the 4+2 infusions of rituximab. The next. How to consider direct antiviral agents and rituximab therapy. You can administer these agents at the same time, but this can be less tolerable to the patients, or with a sequential schedule. But please, let me recommend to start before with rituximab when the manifestation of vasculitis is especially severe. Next. What about the emerging cryoglobulinemia? The next. The introduction of direct acting antiviral agents in 2011 has dramatically reduced the incidence of hepatitis C virus-associated cryoglobulinemias. Patients with sustained viral response, the patient cured, could exceed the number of uremic patients in 2026. And the incidence of cryoglobulinemic vasculitis decreased already between 211 and 218. So, while between 2011 and 2014, HCV-related mixed cryoglobulinemia still represented the largest cohort of patients, major epidemiological changes from 2016 and 2018 can be expected. And non-HCV patient represented the largest cohort of mixed cryoglobulinemia patients. The next. Hematologic autoimmune directed or perhaps non-HCV viral trigger could be now the first hit in the pathogenetic cascade leading to cryovasculitis, including glomerular deposition of cryoglobulins. The next. We examined the clinical presentation and the effect of rituximab in our patient with severe non-HCV related cryoglobulinemia with biopsy-proven renal involvement. The next. 36% of these patients had leukocytoclastic vasculitis, 73% polyneuropathy. 3 out of 5 patients had the type 1 cryoglobulinemia and a low-grade lymphocytic lymphoma. Almost all patients had diffuse membranoproliferative glomerulonephritis. The next. As regard to the effect of rituximab, we used the so-called improved protocol, the 4+2 infusion. And this could be of relevance in interpretation of our result as compared to other experience. Indeed, we achieved remarkable improvement of the necrotizing skin ulcers in 3 of 4 patients, a substantial amelioration of the electrophysiologic parameters of motor and sensory peripheral neuropathy in 6 out of 8 patients, improvement in renal function and proteinuria, together with a reversal of serologic abnormalities in this patient, with much less relapses than described in the cohort, in the French cohort, maybe, or having employed the improved or extended rituximab protocol. The next. Now let me describe very briefly this case of a male 58-year-old patient with no systemic symptoms but just mild arthralgia, previous history of self-limiting purpura, HCV negative, renal function impaired, proteinuria of nephrotic range, microscopic hematuria, normal C4, negative rheumatoid factor, cryoglobulins undetectable, but detectable with a method of precipitation in hypoionic medium, and that was typed as polyclonal IgG-IgM. Next. What we found in this patient at biopsy was exactly what we could expect in a patient with mixed cryoglobulinemia, with complement consumption, rheumatoid factor activity, and the classic and the extrarenal symptoms. The next. What is this case? What represents this case? Between 2008 and 2021, 237 patients with no detectable cryoglobulins by standard method have been shown to have circulating hypocryoglobulins by a method of precipitation in hypoionic medium. Of these 237 patients, 167 were HCV negative. 169 has an established underlying disease, and this trace amount of cryoglobulins were considered to be of accompanying another autoimmune disease. While in 68 cases, patient with 60 that were 62-year-old, majority female, 1/3 HCV positive, but the other HCV negative, 1/3 with rheumatoid factor positive, 1/3 with complement consumption. Only 1/3 of each the cardinal elements to the surrogate diagnosis of cryoglobulinemia. 36 of these patients were type 3 and 23 type 2. Among these 68 patients, 7 had only arthralgia and constitutional symptom, while 61 had one of the 3 major and the cardinal symptoms of cryoglobulinemic vasculitis, that is skin lesions, peripheral nerve involvement, or biopsy-proven nephritis. And note that these patients, 4 with nephrotic syndrome, 5 with proteinuria and hematuria, all of them with impaired renal function, did not have extrarenal symptoms, just a cryoglobulinemic nephritis. So we call this condition as a putative idiopathic hypocryoglobulinemia. Next, please. This is the case of a female who had purpuric, a history of purpuric lesion. The skin biopsy showed the first mixed lymphocytic, granulocytic vasculitis, then urticarial vasculitis twice, and that after several attempts to treat with steroids and dapsone, underwent a definite resolution under rituximab. She didn't have a classic cryoglobulinemia, but an hypocryoglobulinemia. Next. And what about the renal lesion? Light microscopic findings in the 9 patients with hypocryoglobulinemic nephritis had thickening of the basement membrane with segmental duplication and double contour, eosinophilic refractive pseudothrombi, exactly what we expect in a classical biopsy from a patient with mixed cryoglobulinemia. Next. With the classic immunofluorescence appearance with IgM and IgG, and also organized deposits, subendothelial electron dense deposit in location, with somewhat vagal microtubular and diagonal substrate. Just this is the major difference. The fact that these organized deposits are somewhat less organized than classical cryoglobulinemia. Next. What is the difference between idiopathic hypocryoglobulinemia nephritis and mixed cryoglobulinemia nephritis? In the first case, we have polyclonal and trace amount cryoglobulins. In the second, monoclonal IgM, K with K restricted with polyclonal IgG. In hypocryoglobulinemia, the patients are almost all infected by HC virus, differently from classical mixed cryoglobulinemia, and they have very often rheumatoid test negative without complement consumption, differently from classical cryoglobulinemia. Next. Response to therapy with rituximab or other therapy is exactly what we can expect with mixed cryoglobulinemia. Next.
You have 10 minutes, Dario.
Okay, let me close with
questions.
Just with this case in a few minutes.
Yeah.
This is a 33-year-old male with single kidney, you can expect a focal segmental glomerulosclerosis by performing biopsy in this patient, and you find, because of nephrotic range proteinuria in a single kidney, and instead what you find is a moderate thickness in the membranous glomerular membrane, basement membrane with sign of duplication, and intramembranous and subendothelial deposits deposit organized, like the next cryoglobulinemia. This patient did not have hypocryoglobulinemia, but neither hypocryoglobulinemia, was completely negative. Again, he responded quite well to rituximab. The next and the final slide. What we learned about this condition of cryoglobulinemic nephritis in seronegative patients. We learned from Mayo Clinic report showing showing this kind of picture that are exactly what we expect in classical cryoglobulinemia, except the next some more organized deposit than we can expect, with a strong prevalence of type 1 cryoglobulins. The next and the final slide. Let me give you some overall home messages. Ancillary role of direct antiviral agents in treating HCV-associated cryoglobulinemic vasculitis. Key role of rituximab in the management of HCV and non-HCV associated cryoglobulinemia. Cryoglobulinemia is an expanding scenario. Patient who present with the symptoms suggestive of cryoglobulinemic vasculitis and yet test negative for cryoglobulinemia, detectable by standard technique, should be carefully evaluated by hypoionic precipitation method, even in the absence of HCV infection, rheumatoid factor activity, and sign of complement consumption. But there is a subset of patients with cryoglobulinemic nephritis in whom neither cryoglobulins nor hypocryoglobulins can be detected. They are typically HCV negative with poor extrarenal symptoms and often negative rheumatoid factor. And this is the proposal of a new classification of cryoglobulinemic nephritis. Classical form, mainly type 2 and infection, especially HCV related. Hypocryoglobulinemic form, mainly type 3 and HCV negative with fog, microtubular or annular substructure, and this can be important, DNA G9 negative for distinction to versus fibrillar glomerulonephritis. Seronegative HCV form, especially type 1 in half % of cases, with some prevalence of uncommon substructure. Thank you. Thank you from my side.
Thank you very much.
Savino.
Yes, fantastic. Normally I would applaud, but we're online. Very nice overview of a very difficult and rare vasculitis. So let me ask 3 quick questions because it's a lunch meeting and everyone is finishing their lunch, moving onward to their next appointment probably. So just 3 brief questions. So the extended rituximab therapy, what is the rationale to do 4+2?
The rationale is to achieve a prolonged B-cell depletion that assure first a complete B-cell depletion. When I mean complete depletion, when I say complete depletion of the lymphocyte, I intended 0,
Right,
not
right.
2, not 5, 0, for enough time to change in some way the the immune imbalance with increase of T regulatory B cell and prolonged depletion of B cell.
Yes.
A more
Okay,
prolonged
understood.
depletion assure a more prolonged disappearance of clinical symptom and less relapse.
And with as a follow-up question, do you use the cryocrit, so the level of cryoglobulins, as a guidance for your therapy, which you all treat patient towards 0?
Look, we of course use to measure cryocrit, but not given to this parameter an exceptional relevance. The surrogate biomarker T4 and rheumatoid factor are much more important to show an amelioration of the laboratory.
Which is a very nice bridge to the last question, complement activation in cryoglobulinemic vasculitis. Of course, C4, as you mentioned, is a good marker. And especially in this new classification you give, people are wondering immune complex MPGN. So I see the overlap from C3G to immune complex MPGN to the cryoglobulinemic renal manifestation. Do you see a difference? Or is there overlap? And with that, of course, complement inhibition, is that something we should consider?
Complement can be is strongly activated by cryoglobulins, and the principal, the main cascade, the main pathway is more involved than alternative pathway. But due to the presence of IgM, the complement is less incorporated in the cryoglobulins. And this is why, despite the strong consumption of C4, cryoglobulins are not captured by the erythrocyte transport system that neutralize, that maintain cryoglobulins in blood in a solid phase condition and not able to deposit.
Right.
What happens if you have only trace amounts of hypocryoglobulins? Of course, you have a complement activation, especially in deposits, but very likely the amounts are not our detection method for rheumatoid factor and complement are not able to recognize the complement consumption
Right.
and the effect. If we were able to detect, for instance, C3D breakdown product, the situation probably changed.
Yes, yes. I want to thank you, Professor Sciascia and Professor Roccatello. This was very insightful. I want to invite everyone to our next week vasculitis webinar on primary CNS vasculitis, which will be chaired by Dr. Carlos Alvarina and Brandolino. You will see them online. And I thank you all for your attendance and have a good working day for the rest of the day. Thank you very much.